And so the one thing that we want to make sure we understand is that Alzheimer's disease is one of many types of dementia, and it's the most common. Other types of irreversible cognitive decline conditions relate to vascular dementia. Vascular dementia is caused from a lack of oxygenated blood flow to the brain. That can happen when someone has a stroke or a series of mini strokes or has other lifelong untreated vascular issues. We also, these are, again, some of the more common dementias. We also see plenty of people with dementia with Lewy bodies. Dementia with Lewy bodies is, again, another dementia with a buildup of a different substance in the brain that kills brain cells and causes a person with this type of dementia can sometimes have hallucinations or delusions, is incredibly sensitive to psychiatric medications and psychotropic medications, and also has trouble with their walking, or what we call their gait. We also have at the far right, frontotemporal dementia. This is actually sort of a subcategory. There's several conditions that actually now fall under the frontotemporal dementia category. But folks with this type of dementia have atrophy in the frontal lobe of the brain and the temporal or the side lobe of the brain. And then at the bottom, we see that we pull out the fact that there is also a mixed dementia, which has to do with the fact that some people end up having more than one type of dementia. An example of that is that, sometimes someone will have a stroke, and then either, at some point later on in their life, they may also develop Alzheimer's disease. So having one dementia does not necessarily guarantee you won't also come down with another one. Or develop another one. So Alzheimer's disease is a progressive degenerative disease of the brain. It destroys brain cells, like we said before, and it causes problems with, in this case, when we're talking about cognitive decline, it impacts memory, thinking, and behavior. Alzheimer's disease accounts for over 60 to 80% of all dementias that get diagnosed. So of course, that's why we end up inadvertently using them interchangeably, the terms Alzheimer's and dementia, but they are different. Some treatments do exist to help with the symptom management of Alzheimer's disease. However, Alzheimer's disease is eventually fatal, unfortunately, as are the irreversible conditions that I mentioned on the previous slide, such as frontotemporal dementia and Lewy body dementia. What I want to just quickly say about that, though, is that there are ongoing treatments that are being researched right now and going through the FDA approval process. So we're very much looking forward to hopefully having some new treatments, disease-modifying treatments out in the market soon. So this isn't something I can click on, but food for thought. Maybe just raise your hand, either if you're showing your video or if you just want to click on the little icon, so the kind of emoji hand shows up. But I'm curious if you think Alzheimer's disease is a normal part of aging. So if you're on video, maybe thumbs up for it's true, or thumbs down if it's false. This is a very common, okay, good. Marcia says no. So we get asked this question all the time, and the answer is no, Alzheimer's disease is not a normal part of aging. Thank goodness, right? So as we described before, dementia is a general term that describes problems with cognitive functioning that are severe enough to interfere with a person's independence and day-to-day life. And Alzheimer's disease is the most common type of dementia. However, not everybody as they age will develop Alzheimer's disease, and dementias of any kind are not a normal part of aging. So if someone is having a cognitive issue, whether it's in their 40s, 60s, or 80s, it really behooves that person, or us if we're the caregiver, to have them seen by their medical provider so we can figure out what's going on. Just a couple of quick statistics, including this one, which is that 1 in 3 seniors in the United States dies with Alzheimer's disease or another type of dementia. In New Hampshire specifically, I know we have a couple people from out of state, but in New Hampshire specifically, we have 26,000 people living with Alzheimer's disease specifically. And approximately 30% of those folks are living alone. So we're talking about a vulnerable population that is made even more vulnerable by the fact that they live alone. So these are some quick risk factors. As we age, our risk does go up of developing Alzheimer's, but again, it's not a guarantee. So if you're over the age of 65, you have a 1 in 9 chance of developing Alzheimer's. If you're over the age of 85, you have approximately a 1 in 3 chance of developing Alzheimer's. But I'm a glass half full kind of person. So if you're over 65, you have an 8 out of 9 chance of not developing the disease, and so forth. Now, family history also has its place in terms of a risk factor. If you have a parent or a sibling with cognitive decline, you are more likely to develop the condition. And what I would say is that if you've got a very robust family history of this, meaning like all your older siblings and your parent and grandparent, if they all have some form of cognitive decline, then I would really keep an eye out on it and speak with your physician so they can keep an eye on you too. Head injury is also a risk factor. We obviously want to protect our skull. We want to protect our brain, which again, head injury can impact future risk of cognitive decline. We also want to acknowledge that there is a huge connection between our heart and our brain. The vascular system and is very much connected with our brain and fuels our brain. So vascular and cardiac issues do reduce blood flow to the brain and have been shown to increase a person's risk of developing cognitive decline. Some research that came out a few years ago shows that fewer years of education actually has shown to increase a person's risk of cognitive decline. So just briefly, these are stages of Alzheimer's disease. Someone with normal functioning would be considered in this kind of teal, light blue category of asymptomatic functioning. They have no cognitive symptoms, but maybe they're just starting to have some underlying biological changes in the brain. Someone who has mild cognitive impairment, that is a clinical diagnosis that describes someone who is having some cognitive issues, but that are not significant yet enough to impact their day-to-day functioning. Because when it does start to impact their day-to-day functioning, we move into the dementia due to Alzheimer's kind of category, or a dementia from some other source. So we have roughly 3 stages of Alzheimer's disease: mild, moderate, and severe. There's no specific time frame that someone will be in each of those stages. And honestly, they're very much fluid. Sometimes when I'm working with a family, the person seems very alert and lucid in the morning, and they're having a great day. And by the afternoon, their either functioning has slipped or they're more confused. And, it seems like they're in a different stage when really, these stages can ebb and flow from day to day or even parts of a day. Oh, and by the way, in a minute, we're going to be talking just briefly about some of the more significant symptoms related to the end stage of the disease. Actually, right here, I thought there was a slide in between. So once a person is quite compromised with some form of cognitive decline, these are some of the symptoms that you're likely to observe or experience. The world for them is very much experienced through the senses. So we really want to try to engage that if we're the care provider. Their impairment in memory increases. So their memory is very much impacted. They may not recognize close family members. At this stage, they need help with all areas of care. Language becomes very much compromised, and they may only be able to verbally communicate short sentences or phrases or other verbalizations. Again, there's quite a bit, if not total, dependence on the care provider. Their physical abilities diminish, so people may not be able to move around as much. They may need help with feeding. They may need help with all areas of care, bathing, dressing, and so forth. A person with cognitive impairment may require assistance with decision making, or may even need a proxy to make decisions for them. And I just wanted to also point out that we have a new way of thinking about the late stage of the disease. Traditionally in the past, it was really focused on the physical ailments, if you will, the physical changes in a person's functioning, and the rest of the person was not necessarily considered formally in their sort of treatment options or their care planning. And that's very different from how we approach people living with cognitive impairment nowadays, which is a much more holistic kind of wraparound approach that recognizes that a person's cognitive decline doesn't define who they are, that they are still very much themselves, and that we want to try to engage and connect with those parts of that person as much as possible. And of course, the current status of caring for someone in the late stage is very individualistic. And by the way, so sorry, Rebecca, I was trying to get through without taking up too much time. So we actually have 2 polling questions. So I'd like to ask Rebecca if you can pull up poll number 1, which I was supposed to do halfway through what I was talking about, but I don't know if I'll be able to see that. Let me know. Okay, there we go. So if you should see a polling question pop up on your screen. How many of you have a diagnosis of some form of cognitive impairment or are caring for someone with cognitive decline? So if you want to click on that, it'll be kind of interesting for all of us to see. Okay, great. So everybody that, oh, good. Yeah, we'll give everybody like 15, 30 more seconds to chime in. So have you been diagnosed with some form of cognitive decline? Are you caring for someone who has cognitive decline, or does cognitive decline run in your family? Okay, so we've got about half of folks that answered the poll, so that's very helpful. Thank you for participating in that. So it looks like a lot of people have this that, running in their families. That's really interesting. Can everybody see the results of that? I don't know if I'm assuming they can.
Yep. Yeah, we can see the results.
Okay, great. Thank you, Alex. And Rebecca, do we want to get to the other question as well? I think I had it. Yeah. Okay, so question number 2. There's nothing I can do to reduce my risk of developing cognitive impairment, especially if it runs in my family, excuse me. So do you think that's true? There's nothing I can do or you can do, or false? There is something we can do? Or you're not sure? Oh, great. Everyone answered this one, just about. That's great. Okay, so most people think that it's false, that there are things that we can do to impact the risk of developing memory impairment. So great. So so speaking of that, there has been a growing amount of research that is looking at all of the different ways that we can hopefully reduce our risk of developing cognitive impairment. Some of them are listed here, whether it's low education, which I mentioned in one of the previous slides as a risk factor, midlife hearing loss, which we have seen sensory impairment be confused with various forms of cognitive impairment. Obesity, late life depression, and depression in general in older adults is widely underdiagnosed. Smoking, physical inactivity increases our risk. Hypertension, also known as high blood pressure, diabetes, and social isolation. So social isolation, when we think back to the pandemic a couple of years ago, was rampant and really significantly impacted people living with memory impairment and really accelerated for many of them their impairment. So this is a quote: while public health interventions will not prevent or cure all potentially modifiable dementia, intervention for cardiovascular risk factors, mental health, and hearing may push back the onset of many people for years. Even if some of this promise is realized, it could make a huge difference, and we have already seen in some populations that dementia is being delayed for years. Dementia prevalence could be halved if its onset were delayed by 5 years. And not only would that give people more quality time for themselves and their loved ones, but it would put a big dent in the fiscal impact of Alzheimer's and other dementias on our healthcare system. So you can just give me a thumbs up or, answer this however you'd like in the chat or whatever. There is currently no way to diagnose Alzheimer's disease. Do you think that's true or do you think that's false? There is currently no way to diagnose Alzheimer's disease. So let me go back to that real quick. So that's kind of a trick question. Rebecca and I have had this conversation. So I think technically speaking that some medical providers still say that a person has to have passed away before an autopsy can be done to show whether the evidence of Alzheimer's disease is actually evident in the brain. However, what I like to say, and what I've said for many years now, probably a decade, I don't say that anymore, because we have come so far with brain imaging and some of these tests and assessment that are listed here on this last slide, that we can very clearly diagnose someone with Alzheimer's disease. Some of the assessments, for instance, laboratory testing, blood work, or, evaluating urine, a lot of times those will rule out other conditions like an electrolyte imbalance or a vitamin deficiency or an infection or a thyroid issue or all manner of things. So what I say is that a diagnosis is a puzzle, and if someone has access to as many of these types of assessments and tools as possible, then the person can get an incredibly accurate diagnosis. Once something, the more common things are ruled out and we figure out that it's some form of dementia, and then we narrow it down from there. And that is the last slide for me. I want to pass it back over to you, Rebecca, and I'm going to unshare and we can continue on with the conversation.
Thanks so much, Melissa. And welcome to anybody who may have joined a little bit late, but we're just reviewed some of the basic information about dementia and Alzheimer's. And now I'm going to give you a speed reading course in advanced directives and advanced care planning. How many people, and you could put in the chat, have an advanced directive, which I'm going to assume if you have one, you know what that form means and is, and how many don't. So we're talking about the term of art is advanced care planning. You'll hear that tossed around, advanced care planning. And that is a process that can start and should start at any time. A lot of people now are urging their kids when they go off to college to do an advanced directive, because I'm just going to guess that a lot of us on this Zoom are of an age where we can remember some of the horrific stories of people like Karen Ann Quinlan, and that, remember, the people who were kept alive forever on life support because the family and the courts couldn't agree what to do. Karen Ann Quinlan, I think, was 19. I may be wrong about that, but there was a spate of cases back in the 80s, and all those youngsters, were in their late teens, early 20s. So this is not just for old folks. And the actual tool is called an advanced directive. That's the document that one signs. And it has the, like the little check boxes. Advanced care planning has been changing a lot recently to go from the form that somebody might put in front of your nose when you go into the hospital and you're going to have surgery, to real attention to the importance of conversation. with the people in your family, those who matter most to you, and especially the person who is named on your form as your medical durable power of attorney or your medical proxy. And that's the person that you're really trusting with your life, because they're the ones who are going to speak for you when you are unable to speak for yourself. And maybe you're in surgery and you can't speak for yourself and something happens and they need to know what to do. Maybe you've had an accident and you're in the ICU or the ER and you're not conscious. This is when your proxy gets called. But tonight we're talking about this much longer term situation with dementia where you may be physically very fit and you are no longer able, you don't have the capacity to make these decisions for yourself, as Melissa was explaining. So I think that's why probably we're all here, is a certain amount of trepidation about that. At least that's certainly true for me. I'm going to share my screen again and show you. Let's do this as a full screen. So in New Hampshire, there is a fairly new form of the advanced directive. This is the cover. Every state has one. You can find this online in New Hampshire at healthynh.org. And if you do a Google search, just make sure you're getting the 2022 version. The old ones still pop up, but these things are they're established by statute. And in New Hampshire, the legislature revised it last year. So if you do not have your directive, it's a great time. Any time is a great time, but now to do this new form. If you have one, you may also think about revising it with the new form. And if you're living in another state and don't have these, please look it up. You do not need an attorney to do this. There are people in the healthcare field and others who are helpful, and that's actually something that in our resources that we will send to you after the program in a few days, we'll talk about some other resources to do these. Okay. So that's just a few questions. Do you have a written one? Do you know where it is? A lot of people do these and they stick them in their desk drawer, or maybe they're in their safe deposit box. And you know what? That's not going to help you if you're taken unexpectedly to the hospital and are in the ER unconscious. Have you talked about the advance directive and your wishes with your proxy or your medical power of attorney? Do you know if your advance directive is actually part of your medical record? You should ask, because some people are often surprised that it is not. And I've heard too many stories of surgeons in the ER in a hospital, like right here, saying, where's the advance directive? We know it's on file and they can't find it. So that is not a trivial question, knowing whether it's part of your medical record. And does it accurately reflect your values, goals, and wishes, which may change over time? And really drilling in to what your values, goals, and wishes are is one of the reasons that we're doing this, New Hampshire Alliance, doing this at all, and why we started this series about talking about death won't kill you. So we can flush these out much more completely for ourselves and have better conversations with those who matter most to us. So specifically, why are we talking about dementia and the need for advance directives? And I'm going to tell you a story. This is an article that was published in the Washington Post, you see, in 2019. And I remember reading this. Doctors are torturing dementia patients. It's unnecessary. I read this article in November. It was about 4 months after my mother died with dementia. And She was in a memory care facility, a very fine one. My father had cared for her for 7 or 8 years with increasing incapacity on her part. And just a month before, she died in September, and I think it was in August when my father finally agreed it was no longer safe for her to be at home. And she moved into a long-term care, memory care facility. And she no longer remembered who he was. She would occasionally ask him if he was married, though. And I would say, he would say, yes, to you. And she'd look at him very quizzically. And I said, Dad, just tell her no and see what she says then. So she was, had the habit of getting up in the middle of the night and wandering around. And we told the facility that that was the case. And sure enough, she did. And my father got a call at 1:30 in the morning that said, your wife has fallen. She has broken her hip. She has a concussion. We want your permission to airlift her to a major hospital so that if she needs brain surgery, it can be performed there. And my father said, basically, are you insane? This woman, she's 86, she's in this condition, and you want to perform brain surgery? The helicopter ride by itself could kill her because she'd be so disoriented and confused without him. And thankfully, so they said, well, then we'll keep her here, but she'll go on hospice. And she did. And thankfully, the next day, a hospice nurse said to him, took him aside and said, you made the right choice. I will be forever grateful for that person. And when I saw this article a few months later, I thought, wow, that would have been torture for my mother to make that trip without my dad and be in this new place. And he had the wherewithal to make that choice. Now, I'm not saying that choice for others is right or wrong, but he knew it was the right choice for her because they talked about this stuff. So this article really stuck in my head. And I want to tell you just a little bit more about it. The writer is a board certified emergency room doctor with more than 30 years of experience in emergency medicine. And he writes, about 1 in 4, Melissa said 1 in 3, but a lot of elderly people will develop dementia. Many of them will be tortured by doctors. I should know. I am one of those doctors. He writes, I recently tortured an 88-year-old woman with advanced dementia. Her mind was gone. She didn't know her own name. Like other advanced dementia patients, she suffered incontinence, aggression, immobility, unaddressed pain, and more. Her quality of life was dismal. Her family brought her to the hospital because she had a high fever and was more confused than usual. I knew that she was near her end. And he goes on to say that he asked the family what he always says to families who are managing a relative's final days. He said to them, do you want us to do procedures that may well be painful and will not improve her quality of life? Or do you want us to let her go in peace? And he says that with this choice, some families allow nature to run its course. They decline medical interventions beyond comfort care. And families that understand that doctors can neither cure nor reverse dementia are more likely to choose that. Let nature run its course, comfort care only. Other families, he says, consider it imperative to opt for all possible medical interventions. Unfortunately, this includes invasive procedures that cause transient or lasting discomfort. Meanwhile, these procedures cannot improve dementia and yet can accelerate it. In my experience, he writes, most families choose the second option. That includes my patient's family, who asked that I do everything possible to treat her. And that's what he did. And he then described those treatments and her discomfort, and that she only lasted another 24 hours, and thought, wouldn't her death have been a better one with her family around her, focused on her, and not hooked up to a machine with a breathing tube, the rest. So he's not saying that the family, everybody's got to make the choices that they feel are best. But documenting what you want, what we as individuals want is so critical here, so families actually know. And that is his plea. So there are places to help do that. And he says, don't leave it in the desk drawer. Put your directive out where people can find it. If the FAST squad, the EMTs come, videotape your wishes. Find your medical power of attorney, your proxy, who will really stand up for you, enforce your wishes, and then share those with your doctors and your family. So that's why we are focused on this, on advanced care planning generally for everyone, and particularly for dementia, where by definition, you are not able to speak for yourself and in those advanced stages. So we have several tools that we are going to offer you. And I want to make it very clear that we are not giving you any instructions or any advice about what is right or wrong for you. The only thing we are asking is that you think about it and use the tools, do what you feel is best, and not leave it up to chance. So the first tool, and there are three, is online, and it is from Compassion and Choices, which is a national organization dedicated to better end-of-life experiences and options. And it is through their website. Again, we will send out links and all this stuff after the program. So their Dementia Values and Priorities tool is a very robust system that they developed fairly recently in response to survey work they did among Americans, asking about what people are concerned about at life's end. And so many people said, concerned about having dementia and not having my wishes followed. And once again, your wishes may be for very little treatment. Your wishes may be for everything available. This tool is just a way to help you flush that out. So it goes through a series of questions, and for each one, this is just, I'm going to show you some examples. There are 4 choices. I want to live as long as possible, do everything you can. I want no life-saving treatments, meaning like the woman in the ER that the Post article was about. I don't want a breathing, I don't want to be intubated to breathe. I don't want a feeding tube. I don't want surgery, dialysis, these invasive kind of life-saving treatments. Or keep me comfortable, but stop treating me for other diseases, like my heart condition. If I get pneumonia, do not give me antibiotics, but keep me comfortable. And finally, there's keep me comfortable, and if I reach this point, stop. feeding me and giving me water so I can die peacefully. So they have that choice for each of their, what they call markers. This one, I don't know who you are, but I still smile and seem happy. Or I'm angry and violent, but I can be medicated and I'm okay. So if you're at that point, how would you feel along that continuum of the four? Or I no longer have language. Or I can't feed myself. So you go through the long list, checking the boxes, and then it asks you to kind of review. And if you are experiencing only one of the following, would you make any change in your choices? So I am only no longer able to bathe myself, but everything else is I can still do. And then it asks you to take these same 15 markers, and what if you're experiencing 2 of them together, or 3 of them together? And so once you go through this process, you have at the end a directive that really spells out in a pretty granular way what your wishes are. You print it out, you share it with the people you need to share it with, your physician, your proxy, your family, the rest. And you can change it. So the assumption here is that you can revise this as your conditions change. So the next tool is also available online, but it is it's not, you would print it out and fill it out. And this is from Dartmouth College right here in New Hampshire. The Dartmouth Directive for Dementia was also developed as a way to add more nuance to the standard advanced directive. So it is meant to be a supplement to it, just as the Compassion and Choices tool is. And it too, like the Compassion and Choices, goes through the beginning of really talking about what is dementia, what are the stages. So these are very good educational tools as well. So I'd like to draw your attention to one part of this, which is decisional capacity. So if we have dementia, at some point, we're not able to make decisions for ourselves. So how do we really know, or if we're the caretaker, the care partner for someone, how do we know if they're still able? And I'd like to ask, so I'll just give you a moment to see that more clearly. And this is the Dartmouth Directive. So your capacity is judged in those 4 ways: that you understand the choices, you understand your present condition, you can explain why your choice of care is what you're making, and that you are consistently able to make that choice. So Jennifer Robinson, who, and I'm going to stop my share, Jennifer, so we can see you, is the community liaison for the visiting nurses and home hospice up in the Mount Washington area, and talks with people all the time about directives and has some insight for us on this question about capacity.
Hi, nice to see you guys. I'm really excited that all of you are here and learning about this. Advanced directives are a huge passion of mine. And I go out into the community and help people complete them every day. And so part of making the advanced directive a legal document is a notary or 2 witnesses, and I happen to be a notary. So when I go to someone's house, I can give you an example. Today, I went to someone's house and one of them were in the beginning stages of dementia. And I had to make the decision if the person was able to, if he was oriented, if they had the capacity to understand what we were talking about. There were lots of questions before we could proceed. And in his case, he was fine to answer these questions and I felt comfortable. I have had cases where they were not, they didn't have capacity to make these choices and I had to say no. So I always encourage people, as soon as you learn about it, an advanced directive, go and do it, complete it as soon as possible. And make sure you have the conversations with the people who you name on your document. Thank you.
Jennifer, we've talked a bit about that we know people with dementia often have better times of the day and sometimes can feel be quite lucid and then not. So what can people do to kind of take advantage of those moments or those times that they, you know, they can have the conversation when the person is in a more, probably a little bit more, you know, mild stage?
Right. So definitely now in the time of everybody has iPhones, if you record yourself having the conversation with your loved one and can show that they understood the conversation, that they understood what they were choosing, that they understood the implications of the choices that they were making. That's one thing that you can use. I've offered for people to call me when their loved one was in a moment of clarity and had me come to help them complete the document. But definitely recording, I think, is a huge option. And now in the state of New Hampshire, you can have a notary online through Zoom. So if you can find a notary who you can Zoom with, there's a whole process to that, but they could notarize it via Zoom if your loved one is having the moment of clarity and understanding.
Thank you. And Jennifer will also take questions later if people have them. So I'm going to share my screen again, and so we will now go back to, this is still the Dartmouth directive, and they have split this into several parts, which we'll see, medical interventions being the first. And they are asking you to consider whether you want full treatment, limited treatment, comfort only, or let your durable power of attorney for healthcare, that's at the bottom, the DPOA-HC, your medical proxy, let them decide in consultation. And by the level of dementia, mild, moderate, severe. And once again, this really implies that things can change over time. And of course, dementia is a progressive disease. So you may want full treatment if you have mild dementia, or you may not. So same thing going through. And Renee, who's on our call, was one of the people who helped develop this. So she is also available for questions around this particular tool and the other things we're talking about. So then the Dartmouth directive goes on to, where do you want to be treated? So you're okay with a hospital? You're not? Or let someone else decide. Again, depending on what level you are at. And then the big question of nutrition and hydration, eating and drinking. And this is where people, I think, a lot of people talk about this, and we'll have some, we can certainly have some discussion about it. So you would accept assisted feedings, which means tube feedings or intravenous. This keeps people alive for a long time, doesn't it? Limited support or none. And limited support is comfort care, but you don't want any tubes, you don't want any IVs, and no nutritional support at all can still include comfort care, as they say. I'm willing to receive oral comfort care in the form of mouth swabs or ice chips. But I do want to bring your attention to part of that no nutritional support. And if you are in a nursing home or a hospice house, these are institutions, even long-term care facilities or continuing care facilities that have policies on voluntarily stopping eating and drinking. And it might be a very good idea to ask them before you go what their policy is on this. And again, Renee is somebody who can talk with us about that. So you realize it may not be possible to honor this preference in every circumstance because it is against the policy of the institution. So the next tool that I have for you is also available online. It is from, the End of Life Options New York, very specific to just this question of stopping eating and drinking. So the Advanced Directive for Oral Food and Fluids in Dementia. And again, this directive starts with a good explanation about dementia, appointing your proxy, and why you would want to choose one of two tracks. So there's like a column A and a column B. So these side by side here are the two choices. I do not want to be fed by hand, even if I appear to cooperate. Or I would want to receive assisted oral feeding only under the following circumstances. I appear receptive, and I only want to have foods I appear to enjoy. So this is just an excerpt from that. There's much more to it. But this is getting very much to that question that a lot of us think about with people who are really declining, or, I remember my father finally understanding this with my mother. He said, "Are we really helping her by feeding her?" And that's when she was in almost an active dying phase. So, and once again, I do want to just underscore that this directive is for people with advanced dementia. Okay. So I have for you some samples of amendments to advanced directives that some colleagues have shared, that these are written by real people. And they have really thought through how they want to be treated in the case of their getting dementia. And these will also be made available to you. This is just an excerpt from one. That'll give you just a moment to glance at that. I was particularly, if you get to number 9, do not tickle my lips with spoonfuls. I am not a baby bird. Do not coax me to eat. Allow me to stop eating and drinking. It is my right. I consider it legal that you have offered me food if it is placed within my reach. So that's this person's answer to the institutional reluctance to not feed you. Here is another who wrote, made a video recording. So there should be no doubt about what I want. And again, gets to that same question of nutrition and hydration. And again, this is part of a larger, longer letter. This person was even at the bottom, you see, do not, under any circumstances, come near me with those awful lemon swabs. Oh, Don't provide oxygen. I believe it prolongs my body's ability to shut down and die. So people get pretty specific in these. You may also have the same thing coming from a very different perspective, which is keep me alive. I want to, every day is precious to me. And so our examples here are coming from a somewhat different direction, but that is not to say that we are recommending this or that we think it's wrong in any way not to want these. What we're saying is it's really good to state what you want in integrity to your values and your wishes. And my last example is from a volunteer who did that compassion and choices dementia tool. And at the end of that is a place where you can add your own thoughts on this. And this is what this person wrote. I am not willing to live with advancing Alzheimer's or any other form of dementia. I want to end my life when I'm feeling it complete, while I still have the capacity to make that decision and act on it. So this person is actually saying, I'm not going to wait for my advance directive to kick in because I'm going to make that decision before I lose capacity. I want to stop eating and drinking. I want medical support for that. Better yet, I would choose medical aid in dying if that person was in a state where that was legal. I will make my decision based on consultation and my own beliefs about autonomy, choice, and spirit. So just another example of how this person was considering these. I'm going to stop the share and I just want to reiterate once more that making these choices, putting them in writing, having them on video is a gift that we can all give to our loved ones and even to our physician, I think, because they can in good conscience know what we want. There's some physicians on this call who can attest to that or add their voice. In fact, I think Wendy's going to put in the chat a comment from one of our physician colleagues who couldn't make it tonight. So it's a gift to others as well as to ourselves. And that I want to turn to the questions of how we make sure, once we've done these directives, written the amendments, how we have them followed. And this is where Renee is really the person to talk about this. And we're in a medical situation. We have our directives, hopefully, but there are a lot of other people involved. There's the medical team, there's the institution, there's the family. So Renee, I thought we could talk a little bit before taking questions just about some of the common obstacles that you see to getting advanced directives followed. And I'd like to start with the first one, which would be what if you can't find it? What happens then?
But if they can't locate an advanced directive for you?
Yeah, you have one, but it's not.
Yeah.
Nobody can find it.
So that is a really interesting situation that the medical team and the loved ones of the individual are going to find themselves in. So if this is New Hampshire has a surrogacy law which will allow someone to step in and make medical decisions for someone. And that's a particular statute in New Hampshire. However, if you were over the border here in Vermont, where I live, we do not have that statute available. And so there is no one that can make medical decisions for us. In that event, if you live in a state which does not have what's called a surrogacy law, then there is no one who has legal authority to make decisions for you. And in that event, someone is going to have to take out an adult guardianship through the probate division for you. And that is not what you want when you're in a medical emergency, because that is going to be a long, cumbersome process to go through to give someone the authority that you can grant in a power of attorney document, an advance directive. In New Hampshire, though, with the surrogacy law, there is a list of individuals who would step in for you under the statute. And for those who might like to take a look at that statute, the actual, what's called a New Hampshire RSA is 137 J35, surrogate decision making in New Hampshire. Okay. And here's the list of individuals. First, it will be a spouse, a civil union partner, or a common law spouse. Then an adult son or daughter. Then a parent. Then an adult brother or sister. Then an adult grandchild. Then an adult aunt, uncle, niece, or nephew. Then a close friend. Then an agent with financial power of attorney over you, or a conservatorship, or a guardian over your estate. And if we can't find any of those individuals, the attending practitioner actually will identify someone. So those may or may not be the people that you would want acting for you, or they may or may not be willing to act for you. But there is that default statute in New Hampshire, but it is not available in all other states. And as I mentioned, it's not available right over here in Vermont. So the message there is the accessibility of your advance directive, creating one, and the accessibility of it. And when we assist individuals with creating their advance directive and the dementia directive as a supplement to it, we encourage them to put it in the medical records division of any medical facilities where they normally get treatment. So put it on file with Essential Records there. Give it to your primary care physician. If you go to a clinic, but you're also seen at DHMC or another regional hospital or a VA center where you spend 6 months down in Florida, put it on file everywhere you would reasonably receive treatment, so it's accessible. There's also a national directory you can register it with. In Vermont, we have a state registry, which is called the Vermont Advance Directive Registry. It's free, and you can put on file your medical directives with them, and a card is issued, and that those directives can be accessed anywhere you receive treatment, whether it's over the border in New Hampshire or while you're on vacation. New Hampshire doesn't have a state directory, but there is a nationwide one called DocuBank. And it's a nominal fee. I think the last time I checked it was about $40. You can put your medical directives on file with them, and they do the same type of thing as the Vermont Advanced Directive Registry. You're issued a card, and that card can be presented anywhere you would need medical care in the country. Aside from that, having your agents have copies of this document. This is one document that you shouldn't be stingy with giving out copies. Give the copies to your agents that you named in there. Your primary and the alternate and the tertiary, if you have one named. Some people will put it right on a magnet on their refrigerator. Some people put it on a little thumb drive and carry it around. I've even had clients say they've made up one of those little rubber bracelets that says where their advance directive can be found or who to call to access it. So there's all kinds of creative ways to give the information on where it is. And you may have more than just an advance directive for healthcare and a dementia directive as a supplement. You may have a POLST, you may have a COLST, you may have organ, tissue, and body donation directions. You may have a do not resuscitate order or a do not intubate order. All of these things can get organized and put on file with some planning. The question posed by you, Rebecca, what happens when they can't find it? You're going to be looking to the surrogacy law in New Hampshire, as I said, and those may or may not be the order of people you want making decisions for you. Or if you're in a state that just doesn't have it, they can't find it, it's not accessible to them. You will be on pause while we get a guardianship in the probate division over you to make the same decisions that the advance directive gives the agent the authority to make.
Thanks, Renee. Now, another easy question. What if you have your directive and family members might not agree? And I understand that that physicians have a term of swoopers, that people swoop in, like the long lost brother, sister, kid, whatever, feeling that they're going to come in and maybe with a lot of guilt that they haven't been there, are going to come in and, you know, save the day in contrast to what the person wants.
Yes. Or they have opinions that are different than what you've expressed in your advance directive. That comes up a lot too, that a family member will not want a treatment that you want done, or you have decided you don't want a course of treatment and they would want it for you. And so who you have put in your order of agents in that advance directive controls. And if you look at the disclosure that you sign when you create an advance directive, and you can also look at this in the statutes if you're interested in it, and this would be New Hampshire RSA J19, the advance directive disclosure statement. You sign a disclosure before you even work through the document. In the very first sentences there it says an advance directive is a legal document. And there's legal requirements to putting it in place, as we heard Jennifer go through earlier. And the order of our agents is actually, the order is reinforced in the statute itself. Even if you appoint co-agents, the first one named will be the first one they turn to, then the next person. And so that is your mouthpiece when you are incapacitated and you can't speak for yourself. This is who you've appointed when you had capacity to make these decisions for yourself. You've filled out this document when you had capacity to do so, or Jennifer wouldn't have allowed you to put it in place. That notary, that's their job to determine the capacity. So the issue of a family member kind of interfering has really got to be quashed at the medical facility by the agent, hopefully, who can stand strong, or by the medical team who's only going to take direction from that agent if the treatment isn't specifically authorized and outlined within the document itself. And the document really is focusing on end of life care, of course. There's so many other decisions that an agent might need to make for us that is shy of end of life. That's your representative. That's who's standing in your shoes, and that's who should be making all of the decisions in controlling your care.
Thanks, Renee. So once again, the importance of choosing someone who really is not afraid to stand up for you. Yeah, it's gonna be can be fraught.
It can
Oh.
be, yes.
Yeah.
It can be.
So I'd like open it up to questions. And just if you could raise your hand, that would be nifty. And if you want to put it in the chat, please feel free to do that too. Jody,
Yes,
and take yourself
Um,
off mute.
I did. Can you hear me?
Mhm.
Okay.
Sure can.
You had mentioned this national directory, the Registry for Advanced Directives. You said it's DocuBay?
DocuBank, DOCUBANK as one word.
Bank. Okay, thank you.
Other questions? Marcia,
Okay, can you hear me?
Yep.
So what happens in a situation like Katie Butler describes, when a person has completed advanced directives, perhaps even a dementia directive, and been very specific about what interventions they do and do not want at different points, and then as dementia progresses, they change their minds. So, and can a doctor decide, well, this person is decisionally capable, and so you have to then adhere to what they say? For example, if they say, I want everything done, but they're in an advanced stage of dementia, and before that, they had clearly not wanted everything done. So, I mean, my mother was this way in the last year of her life. She kind of changed her, her wishes completely, but she was not in a cognitive state that she was in when she was, the first 80 years of her life, when she was absolutely clear about what she didn't want done. How do you deal with a situation like that?
Rebecca, do you want me to address that a little bit from what I've
Sure.
seen? Oh, okay.
Thank you.
So Marcia, this is where there is no advanced directive in place, or there is, and they're expressing something contrary to it.
Yes.
Okay. So one of the changes that's come along, and Rebecca, I'm not sure if this is what you were referencing in terms of the changes to the advanced directive, but one of the questions that's come along into these directives now is, what if I make objections against what I've put in my document? So I've said I value the quality of my life over the quantity of my life by the answers I've chosen, but now I'm in this state and I'm expressing objection or a contrary view. The advanced directives that have that question in there will ask you, do you want your agent and your health care professional to follow what you've put in the document, or do you want them to have the option of listening to you at that moment in time? And you answer that question, whether you want them to actually listen to you at that moment in time. For the advanced directives that don't have that option, in my experience working with these, what's in the advanced directive will control, and where it's not explicitly laid out, Marcia, the agent will make those decisions. And so the importance of the dementia directive as a supplement to the advanced directive, where you can give a little bit more detail in terms of what you would want, not want through the various stages of dementia, is critical, because you may want something very different if you're diagnosed with dementia than you would with another type of diagnosis. My understanding, and speaking with medical colleagues and insurance colleagues, is dementia is the #1 most feared diagnosis of all. Melissa's nodding her head, so is that right? Okay. Is the #1 most feared diagnosis. And so this is why we're emphasizing this and encouraging you to do everything you can to put your wishes in writing as succinctly and directly as you can, because once you get to severe stage or moderate stage dementia, the cognitive decline is the issue, of course, and you're not going to be communicating the way you would when you had capacity. So capturing something in writing is the point. Honoring wishes once that cognitive decline has come is going to be a matter of, in my experience, has that question been addressed in the advanced directive or not? And if it hasn't, and you don't have anything specific in a dementia directive, that agent is going to make the best choice with the recommendation of your medical team.
Thanks, Renee. And I want to say here that we would like to offer, and this is a question for you all, we would like to offer a follow-up session to this, if enough people are interested, where you might go off and fill out one of the or several of those forms that we've shown you and that we'll send. Maybe write a letter, do the things, draft these things, and then if it would be helpful to come back and in a group discuss these, what our questions are, what our concerns are, kind of poke holes in them. How many people just right now think that might be of interest? Just maybe a show of hands. So, so we would thank you. Thanks. And again, this is part of our mission to make this really a peer-to-peer learning opportunity and build some community, so we're not feeling like we're all trying to figure this out alone. And I'm sure many of us have the experience of feeling like we're going through a lot of this stuff alone, and yet we know there's so many people facing the same things. So Renee, I'm going to ask you this again. Patty asked, how does one go about removing an outdated directive so the most recent directive is being utilized?
Yeah. So the newest in time is always going to win. The issue there is who has the one that's newest in time. So again, where is it on file and is it accessible? You can revoke it in writing, but it kind of causes the same kind of problem. If you haven't disseminated all of that, a copy of that revocation to every place that may have a copy or every person that may have a copy, then they don't know it's revoked. But for legal purposes, the newest in time will cancel out the old one, and that is the document that will control. If you are putting them on file with a registry, then so the Vermont Advanced Directive Registry or DocuBank, as I mentioned, the nationwide one, you can send in the paperwork that says, I revoke that one and I put this one on file. So you've really got to give it some attention, but the rule is newest in time wins, but it's got to be everywhere it needs to be, with your agents, with your facilities. It's got to be accessible. Oh, Rebecca, you're muted.
one more question from the chat, and then I want to conclude with a couple more remarks. But Renee, can you speak to the activation of the advanced directive? If I'm no longer of capacity, will it stay activated?
I had muted myself then. That's a great question. Again, it depends on your version of the advanced directive. Some of them will say, when do you want this to be activated? Now, when my doctor determines that I can no longer make decisions for myself, so your medical team has determined your incapacity, or when this happens, ... So if your advanced directive doesn't have that question on there, then it's going to come into effect when your medical team determines that you are either short-term or long-term incapacitated. So they define that term, the medical profession, essentially, and they say because of a short-term issue, a car accident, maybe you're in a coma, or so that would be a short term, you're going to recover from that, or long term progressing dementia, you're going to be incapacitated. That's going to be the trigger, unless it's explicitly in the document, your direction. Once you gain capacity back, if you do, in the short term example, like a stroke you'd recover from, then by law, you have capacity and that agent no longer has the authority to act for you. But having said all of that, there are plenty of cases where that has been argued in the courts, where one person says, you know, mom doesn't have capacity, and mom says, yes, I do. I don't want my agent acting for me right now.
And June asked what will be our last question. In the event of an emergency, I love this question, June, will a hospital automatically check DocuBank? Renee.
Will they automatically check it? No, they won't. So this is, again, an accessibility issue. Are you going to a hospital that you would normally get treatment at? If so, it should already be on file. If not, because you're traveling or on vacation, then this is an issue of, do you carry, you know, copies or a thumb drive with your advanced directives on it everywhere you go? Unless, you know, someone you're with says, oh, right, her card is in her wallet, let me get it for you so we can dial into DocuBank or the Vermont Advanced Directive Registry. Short of that, again, it's the accessibility. I have had clients say they've printed off 10 copies of their documents and they keep it in a file in the car, or they keep it in a thumb drive they throw in their suitcase. Accessibility.
Thank you. And I'm going to share my screen once more, and we're going to move off this to thank you all and just reiterate that I think these are the values that we at the Alliance for End of Life Options are have really landed on as containing what we're talking about, our individual autonomy, but we're all in relationship. And so all of these decisions are made with a balance of values and a balance of goals, and good conversation taking place over a long period of time, not sitting in the ER outside fretting, is the way to start trying to do that. And that this is actually life affirming. We're valuing life and quality and individual values and relationship. And we started this organization because all of us involved have experiences with dying loved ones where there was unnecessary suffering. There must be better ways, we think. If you think so too, let's work together to make our culture more open and informed with less fear and denial around death and dying. Everyone will benefit. And in order to do this, we need support from people like you. That's all where it comes from. You can make a difference with financial support, volunteer, and tell others about this. And I want to thank you on behalf of all of our friends and colleagues and all of you who have shown up this evening. This is, I think, pretty courageous work to come and talk about this stuff. So we will be back in touch. I cannot promise you it will be tomorrow, but it will be in due time with resources and links and documents and all that. So thank you all and have a wonderful holiday season with those who matter most. Okay, thank you.